Welcome. I'm Joan Anderson with the Lancaster County Medical Society, which is the physician membership organization here in Lincoln. We represent over 600 physicians in the community, and with me in studio today are two of our physicians, Dr. Lisa Peterson and Dr. Dale Michels, both of which are family medicine physicians, and we'll talk a little bit more about that in a little bit. Over the next few months, Dr. Michels and Dr. Peterson will be working with us at the Medical Society to tape programs that we feel you as consumers might find interesting on various health topics. But to do that, obviously, we need your input. So we have established an email address, which is talkswithdocs@lcmsne.org. And I'll repeat that a couple of times throughout the program, where you can go on, shoot us an email, say, gosh, I really would like you guys to talk about this, or I had a question about that. If you don't have access to email, or if it just would be easier for you to pick up a phone, feel free to do that as well. The Medical Society main office is 402-483-4800. So either one of those ways of getting a hold of us and telling us what you would like to see in the upcoming months. To start, what we decided we would do is start with a program, what we are very creatively calling frequently asked questions. We came up with these questions, and obviously I know we haven't captured all of your questions, but these are questions that we frequently get asked at the Medical Society, and I'm sure the physicians get asked from time to time. So that's the first thing we're going to start with. And to start, I think one thing I'd like to just throw out there, for those of us that work in the medical field all the time, we use jargon sometimes that we forget that your patients, consumers such as myself and others, may not always know. So some of these our viewers will know, some hopefully will be new to them. But let's start with what I think is one of the basic premise of what we need to get out in this program today, and that is primary care physician. Dr. Peterson, we'll start with you. If I say, boy, you really need a primary care physician, what does that mean? And
well, primary care physicians are physicians who are specialized in primary care, and that would include pediatricians, internal medicine, and family medicine physicians.
Okay. Now, I know Dr. Michels, as a family medicine practitioner, you see what? Kids all the way?
Well, for many of us, until we will do everything from obstetrical care all the way through end-of-life care. And so when I got a little older, I quit doing the obstetrical care. But as a part of that, we take care of all age ranges from newborns until people who are like my mother at 99, okay, still needing a family physician, so one of my partners takes care of her. So it's the entire age range, okay, the entire spectrum.
If you choose to, but I know, Dr. Peterson, you've limited even though you're family medicine, you have chosen to limit your age group, right?
Right. Well, and I'm in a practice that is family medicine as well as internal medicine, okay, so we see 12 and up.
Okay, so of our 600 members, we have all sorts of options, but truly when we say primary care, we're talking family medicine, pediatrician, and internal medicine. Let's talk about family medicine. You mentioned basically newborn to your 99-year-old plus mother.
Or my grandmother who's 101.
Okay, there you go. But what about a pediatrician? And what age group do they see, and what's the difference between a pediatrician and a family medicine, if any? Dr. Michels?
Well, I think typically they will take care of infants from birth until about 18. Some of them stop a little earlier. Some of them will go maybe a little longer and take care of kids through college. So they can go generally from birth to about 18. The internists pick up where Lisa, where Dr. Peterson does, maybe at 12. Many of them don't start until 18 and then go on through the rest of life.
Now, we frequently get the question of, what about a geriatric specialist? Because that is, we get calls saying, I just want to go to my primary care physician, I want it to be a geriatric specialist. That's a tough one because we don't have truly a geriatric specialist, but internal medicine and family medicine both see the elderly, as we've talked about. So can you talk a little bit about why would people think about a geriatric specialist? What does that mean, and is there
Well, for most of us who were trained in family medicine or in internal medicine, we had training in geriatrics. And the geriatric medicine specialist is really taking a test that shows that you have some special knowledge or expertise, at least enough to pass the test.
Right.
So it may not be a lot of different knowledge. And quite honestly, for many of us who practice in this age range, there hasn't been a real reason to become a geriatrician or a geriatric specialist. One, because we already take care of these people. And two, because even though there is this contact called a geriatric specialist, there really isn't any change in the level of care or the level of reimbursement. Probably some of the geriatricians are usually a little more used to working on a team. They'll work with a bigger group of people. They'll have social workers and other people who they may work with. But realistically, for those of us who are caring for people, it's family medicine and internal medicine doing the geriatrics. And if we get into a problem where we feel like we need somebody for a special need of a certain elderly individual, we can usually make contact, for instance, with the medical center or some place like that.
And I think that's really important to say that we have great family medicine and great internal medicine docs that can just provide that care.
Well, and the other thing with family medicine is I've been in practice for 23 years, 24 years almost, and you've been in practice probably 37 years. Your patients kind of grow old with you.
Right.
So now most of my patients actually are probably geriatrics, but I've been taking care of them for a long time.
Sure.
And so your practice kind of grows with you. And
okay. Good. So primary care physicians, we're talking our family medicine, pediatricians, internal medicine. I know many of you work with what we call mid-levels. Now, sometimes you say that word to the consumer and they say, mid-levels, what in the heck? Well, to us that means nurse practitioner and physician assistant. So let's talk about the difference between NPs, nurse practitioners, and PAs, physician's assistants, and how you guys work with them.
Well, we have a nurse practitioner and 2 PAs in our office, and I think the difference between them, they actually function basically the same, but the difference is probably their education. Nurse practitioner is an RN with a Bachelor in Science of Nursing or an associate degree, and then they've gone on and either specialize in primary care or specialize in the different specialties. And then a physician assistant has followed more the physician's type training where they have a lot of classes actually with medical students and then go through all the different rotations like medical students do.
Okay.
So,
Dr. Michels,
I think that the training is different. We have 2 physician assistants that we work with, and I think from our perspective, the training is probably a little bit different. The educational background of a nurse is, a nurse, as you are, who's trains to think a certain way about the patient. When they go on to get that advanced nurse practitioner degree, they continue to think about the patient in the same way. They just have more knowledge and understanding. Although I think the hours that they take and spend in their training is about 1/10 of what most of us in medicine, in family medicine or internal medicine, take. The physician assistant, on the other hand, is trained a little bit different way and is trained really maybe to work a little more alongside the physician, where the nurse practitioner is trained to just think about patients in a different way. They both have advantages, they both have disadvantages. Some offices, one type or the other, will work better, but they're designed to work realistically from our perspective as a part of a medical team to provide the care for the patients in the practice, whichever practice it might be.
Right. One term that I think really describes it is physician extender. Because I know those of you who work with the mid-levels, it's oftentimes to have them maybe serve those patients that require less extensive diagnostic testing. Is that true?
I think often for us, the physician assistants that we have end up doing the acute care. Somebody calls at 2 this afternoon and they just got a call from the school that their child has 102 fever and is coughing and needs to be seen. They're more likely to maybe provide that acute care. We all try to be available, but sometimes we just can't be available all of the time. So they'll do that. They'll take care of some chronic illness. They develop some special relationships with patients just as the rest of us do. So they'll work with some patients more than others. But it's a lot of extending that, oh my goodness, I don't have time to see them. Somebody needs to see them. Let's see if we can't get them taken care of.
Okay.
And I would say in our office, like my schedule, I'm pretty booked up with chronic care, and so our mid-levels tend to see the acute care, the same as Dr. Michels was saying, as well as preventative care, and also maybe pre-op H&Ps. So, but usually if someone needs to be seen, they can be seen the same day.
But in some clinics, they actually do it really is working with the physician in the best way that it works with the physician. Sometimes they do see the chronic patients, and I think the key is they always have the physician to back them up if they have a need for extra consultation.
Right.
And I think in some of this, they function as a primary care assistant for the physician that they work with, whether it be to record data or to do that pre-op evaluation for somebody who's maybe going to have some relatively minor surgery and they just need to be checked over and looked at and made sure that everything else is okay, so that the subspecialist can proceed with their procedure or whatever they have to do. So they'll work in that situation as well.
One of my favorite questions is, what's the difference between a DO and an MD? Because if anybody looks in the phone book or looks in our medical directory of physicians, you both are MDs, it'll see MD behind your name, but many of your colleagues, it'll see DO behind their name. So, Dr. Michels, do you want to take a shot at that one?
Well, the doctor of osteopathy is trained a little bit differently, and it's trained more with a little bit of an orientation towards manipulation. So they use a little bit of the manipulation like a physical therapist might as a part of their training. Their basic science training is very similar. Their pharmacology training is similar. And almost all of them go through a family medicine, at least in our case, family medicine residency, where they're trained right alongside of an MD. So when they get through with that training, they're really very little difference. In fact, we all think of them as fellow doctors. We don't say, oh, you're only a MD or you're only a doctor of osteopathy. We think about them as really part of the team, and many of them seem to end up in primary care, doing primary medicine, but they do a very good job. They do have a little training extra sometimes with some manipulation that they can do to make some adjustments for people that might help them. But many of them don't even use that an awful lot. They're really just doing primary care, but they graduated from a different school than we did.
And they basically take the same test?
They take the same boards. They can apply for the same, both MDs and DOs can apply for the same residencies. So you'll see DOs as well as MDs in all the different specialties.
Okay, good. Okay, that's one we get a lot, because I think it means a huge difference, and we tried to explain it, and
well, I
so
think
this is helpful.
120 some medical schools versus 20 some. There's more and more coming out of the DO schools, but I mean, there's more schools coming up. But I think 26 DO
Could be.
schools like that.
I think it's important, Joan, when you think about it, to recognize that these individuals are trained as physicians. They just have a doctor of osteopathy. The physician extenders that you talked about before aren't trained as physicians. They're trained to work with physicians. Now, in my office, and I suspect in Dr. Peterson's office, some of our patients say, well, I saw Dr. such and such, who is really a PA or an advanced practice registered nurse, but they really aren't a MD or DO. So there is a significant training difference.
Right. Okay. Dr. Peterson, I know you work with the residency program, and for those of us, again, in the know, in the medical community, we feel so fortunate to have a family practice residency program, and we will be talking about that in another program. But another question we get, well, now we can have you be seen at the family practice residency program. Oh no, I want a real doctor. Talk to me about a resident. What does that mean? And
okay, a family practice resident has gone through their 4 years of medical school, so they've graduated, they've taken their boards, and now they're in a specialty training program, which is family medicine, and it's a 3-year program, and we are very lucky to have it here in Lincoln. So, and they do have supervision. They have a curriculum that they need to fulfill, and they also work with the physicians, the different specialty physicians in the community. They have to get so many procedures in. They have, like I said, a specific curriculum that they do need to fulfill, and then they take boards at the end of their training.
And they have faculty on.
Yeah, actually, they get patients can get some advantages by seeing the family medicine resident, because the residents then go talk to a faculty member. Some of them are volunteer. Dr. Peterson volunteers. I used to do that. Many of them, they have full-time. But after the resident, who does have his MD or DO, so there's no difference, sees a patient, evaluates them, and goes to talk to them. So they actually sometimes can get 2 opinions for the price of that one office visit, because that faculty member has gone through with them what they found, what their recommendations are, and how they're going to approach a patient's problem.
Good. Last one before we move on to maybe a little different turn is board certified. What do we mean by board certified, and what do we mean by not having board certification? Do you want to take that one? Well,
I think for family medicine, actually for pediatrics, for internal medicine, we all have boards, and really what it is it's a group of physicians nationally who develop testing mechanisms to make sure that our knowledge base is current, that we understand what we're doing, that we know what's current in our fields. And of course, family medicine is very broad. Pediatrics is broad within that certain age range, and internal medicine is also fairly broad for adults. So we take a test, and it usually varies with, it's usually a half-day test or an all-day test. Number of questions that are asked now to become computerized, but you go through a test, and in fact now I believe all specialties, every so often you have to retake that exam, make sure that you're current. It used to be that family medicine was the only one, then pediatrics added, then internal medicine, and now I believe all specialties have to go through a certain refresher, redoing that to maintain your board certification. So when it says DABFM, Diplomat of the American Board of Family Medicine, that means that you've taken that test, you are current in that for a period of time. Thankfully, it's about 10 years, so we don't have to do it real often. But it's done on a regular basis in all specialties. And it just says this individual has taken the time to work hard to understand what's current, what's needed, and how best to take care of them as passed a test.
Okay.
Well, and also, you have to stay current with your continuing medical education to even take the test. So there's a continuing education requirement.
It's not like you guys just get out of school and then you get to slide.
Right.
No. And there are some physicians who have chosen not to go that route. Some physicians, older physicians, sometimes say, I don't want to bother taking this test anymore, so I'm no longer going to maintain my board certification. That doesn't mean that they're somehow failing as physicians. It just means they've chosen not to do it. But I think in Lincoln, and you could correct me, Joan, the majority of the physicians we have in our community are board certified in their specialty.
They are. Yes, I believe you're right. I don't know if it's 100%, but it's really close if it's not 100%. But even if someone chose not to be board certified, they still have to do the continuing ed required for their license.
Yeah,
correct?
Nebraska now requires a certain amount of coursework or continuing education every 2 years, which is what our license lasts. Those of us in family medicine actually have a requirement that's about twice that much, so we have to work a little harder, but that just happens to be what it is. But yeah, there is a continuing education requirement for you to maintain currency of your license, which is part of the state's requirement to make sure the physicians who practice here do a good job.
Right. Okay, this is always kind of a tough one because there's so many definitions of a medical home. What do we mean by a medical home? And I realize we don't want to give the 3-sentence version because you go on websites and you could get 3-sentence version. But in the simplest form, what do we mean by medical home?
Well, my response as an old physician is I remember back to the 70s, and there was a television show called Marcus Welby. And Marcus Welby was a family physician who cared for his patients, who tended to put them first, who was available to them, who knew the other specialists in his community when he couldn't take care of the problem, and he provided ongoing care not only to the patient, but often, if you remember, typically to the family. He was dealing with the parents or the kids or the siblings or the spouse, and so a medical home is really designed to come back in the 21st century. We can't do everything that was done in the 70s, but in the 21st century to provide that kind of a home for our patients. That's maybe too broad. There are lots of definitions. Everybody's playing with you have to be this or you have to do this or you have to have this, but realistically, interest in the patient, available for the patient, up to date, knowing what to do for the patient, and viewing the entire family or the entire constellation of family, kids, adults, etc.
And Dr. Peterson, you mentioned a little bit that your schedule is full, but if you have a patient of yours that needs to be seen, that's where those mid-levels that
or I add them on, or
right.
You can always work people in.
Yeah, but the point is you really want them to stay within your medical home, within your practice, because...
And be able to get in right away.
Exactly. Because you have their records, you know them, and so that's one of the advantages of making sure that you have those extra pairs of hands to help you. Okay, so we want everybody to get a primary care physician. We've talked about all of the various things that kind of go into that. What happens if you as family physicians decide, I need to see a specialist, I need a dermatologist, a cardiologist, picanologist? What then? Do you just say, good luck, Joan, go find one? Do you say, how do you go about getting me into a specialist?
Well, typically I try to give them a choice of a few names, so I'm not just saying, okay, this is who you have to see, but then would also send over any notes they might need, make sure they have any lab or x-ray studies pertaining to that problem and what the specific problem is, so try to get that sent over before they see the patient.
Okay.
I think the studies show that in most cases, about 85% of the problems that are presented in primary care offices can be handled by the primary care physician. Right. And so there's only about 15% who need it, but neither Dr. Peterson or I do surgery, for instance, except for maybe some minor, very minor surgery. So when we do that, we in our office and many offices have somebody who's really nearly full-time just making arrangements for patients who need a procedure, who need a specialist consultation with another specialist. The primary care physicians are specialists in the broad range of primary care, so we need what we call a narrow specialist who might be somebody who deals with stomach issues or lung issues or heart issues or skin issues. And for most of those in those areas, they deal with that particular problem, but they're really not trained to deal with the whole family or the whole person type thing. And so we make arrangements for them. As Lisa said, we send them notes, we send them copies of reports we may have gotten. If somebody comes up with a funny looking x-ray or something, we'll send a copy over to the right specialist that we feel needs to take care of them.
Okay. And I think the reverse is true too. So I go see my specialist and I'm going to have surgery or whatever it might be. They communicate directly back to my primary care physician so that you're going to know what kind of surgery I'm having, when, and that type of thing, right?
Exactly, and sometimes there'll be a situation where a specialist, a subspecialist in another area has seen the patient and then feels that there's some other additional information, or based on their findings and what they found, we now need somebody in another field. The classic one would be a surgeon who's operated on somebody for breast cancer, but they really don't take care of the complications beyond the surgery or the chemotherapy if they need chemotherapy or radiation therapy. So that information comes back to those of us in primary care, and then we work with that specialist in that area to help find the best specialist we can in the area where they're going to now need some additional assistance, whether it's chemotherapy, radiation therapy in that issue, or maybe something else is developed and they need another specialist to look at a different aspect of the other area.
Okay. I think really well, two questions. You guys are great, but you can't be open 24/7. So does every physician's office have a way for their patients to access after-hour care? What's the difference between urgent care and emergency care? How do you instruct your patients to...
Well, and that's where it's important to have a medical home so that when you do have a problem after hours, you know what to do. And I think most offices will have someone on call who can give them information or advice. You know, is this a problem that could go to an urgent care versus emergency room? Emergency room is going to be a lot more expensive. So, you know, or is it something they can handle over the phone, or maybe say, well, we can see you tomorrow for this. Yeah.
Okay.
Yeah, a classic example, Joan, would be is somebody calls and their child is maybe 15 months old, has a fever of 102, it's 8 o'clock at night. What do I do? Well, they talk to their primary care physician, whether it's a pediatrician or a family physician, and they say, well, will the fever come down with medicine? Well, I don't know, I haven't given them any. Well, then you better give them some and try that. Do they act sick? No, they're playing in the other room, you know, but their temp's 102. Did they eat supper? Yeah, they ate just fine. Well, in those kind of situations, we can say, you know, I think this is okay. There's no reason for you not to treat the fever tonight, and we'll be happy to make arrangements for somebody to see them tomorrow. If, on the other hand, they call and the temperature's there and the child is clingy and not eating and really acts sick, you know, just laying there, you might think, you might say, you know, I really think you maybe need to go see somebody in an urgent care situation and figure out how sick they really are. And of course, there are, you know, for the emergency room, it's things like we don't want really patients to call us and say, well, I've been having this crushing chest pain for an hour and a half. What should I do, doc? Or I haven't been able to move my arm all afternoon. What should I do? The kind of things that would be in acute care that might really need the hospital situation, those patients would go directly to the emergency room. But a lot of the times you can talk to them, as Dr. Peterson said, one of us is on call. You talk to them, you tell them what to do, you give them some sound advice, and you can give them the option. You can always call me back in an hour if this is not working, and we'll discuss what to do and go from there.
Good. Well, I know we could go on and on, but I'm going to have one last question, and that is, what is a hospitalist? Because I think for some people who've been healthy and haven't been in the hospital, they don't know, and then they get to the hospital, and now we have a hospitalist involved. And what is a hospitalist?
Well, a hospitalist is someone who has been trained, especially just to take care of patients in the hospital. This need has come up with more and more primary care no longer doing hospital care, so this is given a choice there. They work on shift type work, just the same as emergency room physicians. When we use a hospitalist, we try to give them as much information about the patient as possible, and then in return, usually when the patient's being discharged, we'll get a call or a discharge summary regarding the patient.
So the reality of it is we're not in the Marcus Welby days anymore.
In some ways we're not. That's very true, and as I think Dr. Peterson said, many of the times people who I admit to the hospital are often sicker, have many more medical problems. I had one yesterday who was admitted because of back pain, leg pain, abnormalities in the salts in her blood, anemia, hypertension, and something else, all in one person. Wow. And that takes a lot of time to ferret out. And if you're trying to see patients in the office and provide a good medical home, you don't have 2 hours to leave the office and go over and take care of all of that sort of thing. So that's where the hospitalist comes in to help us out. It does involve some communication. And of course, unfortunately, some of those people get sick enough they end up in the intensive care unit. Where yet another group of physicians now called intensivists take care of it. But they live, as it were, 24/7. They're available for that intensive care unit. Because again, people are much, much sicker than they used to. When I first started practice, people spent 2 days in the hospital to have their cataract out. Doesn't happen anymore.
Right. Well, Dr. Peterson, Dr. Michels, I appreciate this. I think this has been a great start to our program called Talks with Docs. This will be the first of many programs hopefully to come. I just want to again encourage you to go to our email and send us an email if you have suggestions for topics, if you have specific questions not related to a specific medical need of your own, because we want you to go to your primary care physician for that. But if you have something you would like us to address, please do that. And the website again is talkswithdocs@lcmsne.org, or give us a call at 402-483-4800. And I thank you again, and thank you for joining us.